The findings that were reported at ACTRIMS are interesting for two reasons. So one of them is, in both Gemini 1 and 2 and Hercules, which were three large phase 3 clinical trials that looked at the efficacy and safety of tolebrutinib versus an active comparator, so teriflunomide in Gemini 1 and 2. But in Hercules, tolebrutinib was evaluated versus placebo in non-relapsing SPMS. So in a subgroup of patients, so about a third, they did have imaging where we could evaluate for paramagnetic rim lesions or PRLs or PRLs. And the interesting findings from what we reported are that number one, across all three of these trials, so in the people who had PRL imaging done, it's clear that when you look at people who are either in the teriflunomide, which was the active comparator in Gemini 1 and 2, and placebo arm, it's clear that your baseline number of PRLs is directly relevant to the risk of accumulating disability during the clinical trial. So that's really interesting because it tells us what many different smaller studies have shown us, mainly cross-sectionally, in that either in untreated people with MS or in people treated with the active comparator, teriflunomide in Gemini 1 and 2, baseline number of PRLs predicts how likely it is you'll develop disability over the 2 to 3 year clinical trial. So it suggests that baseline number of PRLs is a prognostic biomarker of disability accumulation. And this actually has a number of clinical implications and clinical trial implications for trial design in the future. Because if we want to, say, enrich clinical trial populations for people who are more likely to accumulate disability, obviously these findings need to be validated, but it makes sense that we may consider PRLs as a measure that may help us to enrich clinical trial populations. Another really interesting finding was that in people who were treated with tolebrutinib, it seemed that the effect of tolebrutinib on disability accumulation was more evident the larger the number of baseline PRLs an individual had. So it suggests that, in people who are treated with tolebrutinib, baseline number of PRLs may be a good biomarker of treatment response. Again, in that people who had higher baseline PRLs had a more evident treatment response than people who had lower baseline PRLs. So also really interesting because this has never really been evaluated in a clinical trial before. And, in clinical practice, we're always trying to look for better ways to deliver personalized medicine. And so obviously, again, this was a subgroup analysis, a post hoc analysis, but intriguing just because it suggests that maybe PRLs can be used for treatment decision making. So I think obviously we'll need to look at longitudinal data just because right now this was an analysis that evaluated, an individual patients in the clinical trial baseline PRL lesion count and its relationship to disability over time and treatment effect. But again, we need to look at the longitudinal data to have a better idea, but this does suggest that what we're thinking about the relationship between PRLs and disability seems to hold prospectively. And I'm emphasizing that point because, we've seen many smaller studies showing that there is clearly a correlation between an individual's PRL count and motor as well as cognitive disability. But the fact that this was shown in a 2 to 3 year clinical trial is really profound just because, again, to prospectively show that, having a certain number of PRLs greatly increases your risk of developing disability. That's really important to know. And then what does it mean about the effect of tolebrutinib on PRLs? I don't think, again, we can definitively say without the longitudinal data, but the fact that, individuals who had greater number of PRLs seem to show a better treatment effect suggests that, and especially given what we know about tolebrutinib, that it does have the ability to get into the central nervous system at bioactive concentrations, it does support the theory that we have that tolebrutinib gets into the CNS and does beneficially affect cells that we think are relevant to progressive disease biology. like any research study, I think there's many different pros to this study, in that it was done in the setting of multiple large phase 3 clinical trials, and the relevance of PRLs was evaluated prospectively. But obviously, before we make definitive conclusions, it's important that we evaluate these relationships in other clinical trials, and we evaluate this question of whether there is an accentuated treatment effect in other relevant clinical trials as well, because there's a number of other BTK inhibitors being evaluated and other experimental therapies that we think may target some of the disease mechanisms that are relevant to progression in MS. And so I think you need to kind of validate this externally and in other settings before we're able to definitively say that we should be looking at PRLs as prognostic biomarkers or treatment effect biomarkers. But I think as a first study, that has a lot of benefits, because it actually was a relatively large number of patients and done systematically in a phase 3 clinical trial setting. I think it sets the stage for hopefully many other validation studies, and will be part of the pathway to being able to use PRLs in clinical trial settings and in clinical practice, hopefully in the future.